Hey, 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 welcome back to another episode of the Red Pill versus Blue Pill. My name is Dr. DeLon Canterbury. I am your favorite geriatric pharmacist and founder of GeriatRx, as well as the Deprescribing Accelerator. So, hope you guys are doing well. Welcome to another episode. Today, we're talking about some of those myths that I feel some of our providers have when it comes to deprescribing and stopping harmful medications in our seniors. So, we're going to dive on into that today and talk about some common misconceptions that I've found in the game and what you can do to actually capitalize on those myths and how you can leverage your business, how you can change your senior care organization to integrate and future proof yourself in the world of value based care. So, again, if you didn't know, the preface of our Red Pill versus Blue Pill series is to let you unearth the future of deprescribing and break through our broken healthcare system, which consistently rewards and monetizes sick care. We literally make more money the sicker our patients are. So, to break out of that, we got to change policy, we got to change reimbursement laws. But what can we do from the ground level? And so I'm speaking to those people today, those entrepreneurs who are ready to face the future, forward proof themselves, and learn how they can leverage a new skill set with deprescribing, but also grow your business, increase your clients, get your referrals up with this type of service that we know can reduce harm and lower readmission rates and literally provide the quality impact that our seniors are dying to have. I guess terrible pun, but the point is, the point of this is to show that value-based care can not only be sustainable, but how pharmacists, nurses, social workers, gerontologists, people who keep touching our seniors can have an active and important role that could be life-saving and rewarding and fulfilling in our heart, because we know ethically people are just simply over-medicated. So let's get to it. What's one of the myths that we can discuss today and dispel that people think they have to have in order to deprescribe? Deprescribing, in my eyes, is a broad term, okay? Of course, there's the actual act of stopping a medication under the supervision of your provider, okay? We know that's the cookie cutter definition of what needs to be done. But there's so many steps that take place before we get to this point of implementation and sustaining stopping harmful meds. First and foremost, you got to inform and educate the patient, right? We got to make sure the patient has trust and buy-in. And so there are a number of psychological factors that take place before we get to this level of having your patient bought in and sold on stopping a med. I mean, you got to understand, people who have been on this for years, they may think, whoa, you giving up on me, doc? Is there a reason you want to stop this now? And so we got to start with teaching, number one, but also getting that buy-in, getting that trust, and getting that team-based approach to care, where I feel particularly pharmacists have amazing opportunity to leverage their already amazing skill sets in deprescribing and medication management and being the expert in stopping these harmful meds. So number one myth I hear is that, you gotta be a doctor or a medical doctor or PCP or provider to essentially deprescribe. And so let's talk about that, right? Of course, legally, we gotta have a provider's permission who wrote a prescription on whether they want their patient to stop it or not. We know that's a legal thing. I'm not out here telling people to just stop meds willy-nilly and then hope things work out. That's unethical and illegal. We don't play that game. However, even though we need that provider buy-in and agreement with the deprescribing plan, people still think you gotta have to be the doctor to make this stuff happen, when in actuality, it's truly the patient. It's truly that advocate who's empowering the patient to speak up about some of those issues and opportunities to deprescribe in their communities. And so, hey, what's going on, Sue? And so we got to be real with ourselves. Yes, the doctor is important. Yes, we need that legality and that buy-in. But the number one myth is it honestly starts with the patient. Does the patient want to get off that medication? Is the patient aware of a life being free from taking 20, 30 meds when they're 60 years and up trying to figure out life? The truth is, anyone can do that. You don't need to be a doctor to do that. You don't need to be a pharmacist to do that. It does damn sure help. But you can do this with literally asking, yo, are you on more than 5 medications? You are? You're on 10? Oh, you're on 15? You're on 20? Okay, boom. Let's start with a deprescribing plan. Simple. Let's talk about it. Just talking about it is like the number one step you got to take. So I'll repeat that again. People think you have to be the doctor to stop it. And yes, legally, you have to have that permission, but it doesn't start there. The doctors are generally inundated with countless meaningless tasks that they have to do and fulfill each day. And so they're not focused on the meds. They're focused on how can they keep their practice afloat? When are you going to see the next patient? How are you going to turn over the room so they can get that process flow going and get those reimbursement rates up and up and up? Okay, that's the sick care system that we currently embrace. So let's flip the script. Let's talk about how we can change this approach of thinking that people have to be medical doctors and prescribers. You can literally start deprescribing by simply asking probing questions, by simply asking, how long have you been on this? Is it still working? It's not. Oh, it's actually treated your symptoms. You're done with it? Great, let's stop and see how you do. The truth is about 80 to 90% of people who stop medicines that they've been on for a long, long time tend to have no side effects after you take them off slowly. It's already pretty, it's already pretty low. It's statistically shown to be effective and a very low rate of having the reverse. Of course, there's some drugs you got to be a little more careful with, like some psych meds and maybe some benzodiazepines. But overall, most meds can be stopped safely. So again, we talked about how you have to be the medical doctor to stop medications. Not necessarily the case. You can literally be an advocate, an educator, and we'll give you those tools, but you don't have to necessarily be that type of provider. Okay, so that's number one. Number two that I hear often is essentially telling your patients or caregivers to go run and tell the doctor that they're having issues. And yes, intrinsically, we want that to happen. The truth of the matter is reality hits. Our patients are overwhelmed. Our patients are overburdened. They don't have the priority. They don't have the bandwidth. They're barely taking care of themselves, let alone their loved one. They're worried about what they're making for dinner tonight. They're not worried about, okay, in 3 months, I got to bring up that deprescribing plan that DeLon talked about 3 months ago. It's unlikely to happen. And so it's really putting the onus of our broken healthcare system back on the patient, and they're already taxed, right? Religiously in their day, indirectly, directly. Just the time maneuvering through our system is costly for them. They're losing out on work, and their loved ones aren't getting the best care. So again, putting the bill back on the patient or caregiver is what we think will work. It doesn't work. It generally falls on deaf ears. You got someone who might be dogging and can try doing it themselves. But essentially, again, that's hard to pull off. Another myth I kind of hear or see sometimes with maybe more people who just aren't used to this way of thinking of deprescribing is they just don't see the impact. They don't see the value. They don't see why we need to stop some of these medications. Look, these providers have all the intentions in the world to have their patients on the least amount of meds as possible. The truth is, they don't really know how. They haven't been trained how. They don't really have clear-cut guidelines that show them that they can actually get their patients off of harmful meds and do it safely. They don't know that. So assuming that it all falls on the doctor again is a myth. It's false. But really, they're thinking like, what's the value? Why would this matter? Well, let's talk about why it matters. When you have a patient who has constant falls and they're readmitted to the hospital every couple of months and they're on 20 meds, and we know 2 of the meds are causing the problems, then my friend, you're not only costing the healthcare system thousands of dollars, but you're also costing that patient thousands of dollars. The quality of life is decreasing. So that's another metric that's being dinged. Your readmission rates, your reimbursement rates are affected because, again, your patient isn't well managed. They're a repeat offender to our system, and now they're a cost. They're a burden from a population health standpoint because they're incurring costs of their care. And the patient is not happy. You think they want to be back in the hospital over and over again for their heart failure exacerbation, but they have knee pains or they've been taking NSAIDs to help with it on occasion? It happens. It happens all the time. And again, the mindset is we have to refuse the status quo. We have to refuse that doing what we're doing in this broken healthcare system is actually working. We know it's not working. COVID has shown a mirror to that. We know that there are health inequities left and right. We know that there's ageism left and right. We know that there are absolutely prejudices towards those who may be unable to move. There may be movement disorder, disabilities that can affect the outcomes of these patients. The quality of life is already impacted. So again, these myths of, well, I don't see why this is important. Why is this necessary? The truth is they know it's important. Their hands tend to be tied because our system wants them to consistently overtreat with diagnostics and pills and methods that literally don't translate to actual quality outcomes. We know that. And so I don't blame any of the providers. I blame our system. System sucks, okay? I'll say it as much as I need to, but the system sucks. And the providers, honestly, they want someone who could come in with the evidence, with the knowledge base, with the quick, all right, what can I do now? To help them because they need help. The truth is they need help. They want pharmacists. They don't know how to put them in their system. And they also want those other clinicians who touch senior patients' lives, whether you're an occupational therapist, physical therapist. They want everyone who can chime in and see that there are harmful meds, how they can use that. So there are many ways you can address that issue, okay? So again, people think you got to be a doctor. That's myth number one. Okay, you don't have to be a doctor. Telling patient to just tell the doctor that they have an issue with their meds is it feels good. It doesn't work. It's not always sustainable. So that's another myth, all right? Number three, people think it's just some providers just think it's not their job to worry about the meds. And you may be in nursing home. You'd be like, well, we've had Jackie Sue fall another time and well, it's not our problem. They just live here. No, that's the problem. That's the problem. If we are not putting in the effort to help our seniors age gracefully and independently without the needs for unnecessary harmful meds, then my friend, you are losing out on money on someone who can healthily stay in your quarters, but now is in the hospital, or now is transferred to a SNF, or now in an LTC, because you had an opportunity in your nursing home if you had a system in place to teach and advocate and get them off some harmful meds. You already have the nursing staff. You likely already have a pharmacist who's a consultant pharmacist who works with your contracting LTC. So why aren't we just using those same people to look at a wider lens of how we could reduce harm and reduce those costs incurred on our patient system? So that's another myth. People think it's not their role when really it affects everyone's role. I don't care if you're the speech therapist, the social worker, the nurse, the main provider, anyone, the farm, they all have touch points with our seniors. So they all should have an equal role in helping to advocate to deprescribe. That's the way it should be. That's the myth debunked. Okay. And lastly, I know I mentioned like you have to be a doctor, but some people think you just have to be a straight up clinician. Look, I have given many cases and consults about how to stop medications. And before we even dove into the med review, literally me just asking, how long have they been on it? Are they on more than 5 meds? Is it necessary to live? That's 3 questions I ask. It don't take a PharmD to ask those questions, okay? You don't have to be a clinician. I can't tell you how many advocates who are caregivers who just want the best for their loved one ask those questions, and they ask it every time, and they do it until they get the results. So patients can be deprescribers. Changing your diet and exercise, using nutrition can help deprescribe off of other meds, okay? There's a holistic approach to this. It's not just let's shut everything down cold turkey and hope for the best. So you may wonder why this is wrong. We've kind of broke it down, these myths that we've debunked. But essentially, you're putting the onus on back of the patients for some of these ways of just saying, well, ask your doctor. All right, duh. But we know that's not always going to work, right? So we talked about how that's ineffective and the caregiver's already burned out. Again, there are those who don't see the importance of why these meds may affect their bottom line. And so they don't see deprescribing as a need to do on their list. And these are those certain care organizations who may provide like referrals and resources, or even nursing homes, SNFs, whatever. They have a law and FDA F tags that they have to follow. But essentially, if it's checking that list off the box, ain't nothing outside of that. And that's, and again, a sore point in our healthcare system that I think is sorely lacking. Some people simply don't think that our patients not being on these harmful meds that lead to issues affect their business, affect their bottom line, affect their service. If your patient is dying, guess what? You may not have a patient anymore. And unfortunately, like I mentioned, you need patients in your beds to sustain revenue. So why aren't you leveraging pharmacists to be that deprescribing advocate, or other senior care clinicians who have the skill set after using our Deprescribing Accelerator to, again, deprescribe? So let's talk about some of the gaps that are missing in this thought process and why these are myths that are unfortunately problematic, but opportunities for you to capitalize on. We know that there's an issue in this country with over-medicating. So let's just simply start with teaching our communities on the issue at hand and own it. The issue is overprescribing is prevalent, whether it's opioids, sleep meds, antipsychotics in nursing homes. Tell your patient about the problem so that way they can have a look at themselves, what they're taking, and use this as a touch point for your business to advocate and serve like you were supposed to do, which is why we got into this profession. It's to serve. Leverage the tools that are clinically available to help you not just say, well, ask your doctor, but say, oh, wait, you know what? I did a quick check. Look what I saw. I see that you may be suffering from anticholinergic toxicity, just from our nurse who looked at this report real quick. Or I actually see that you may be on more than 5 meds, and one of them is a big no-no in dementia patients, right? We got to start with educating the people that need it the most so that the patient has a right state of mind. The advocate, who could be a senior care clinician, pharmacist, nurse, whatever, has that right state of mind and some evidence that shows, hey, we have a reason where we can maybe just deprescribe. And that way we have now 2 people with the same mission unifying, and we just got to get the provider who wrote it to understand why this is an issue and why this may be harmful. And that's the approach I use. That's the approach I do in clinic for my patients and my services, but it's also what we teach people how to do. So you're not just throwing it at, here's your patient, here's where you go, but we're building a case together, okay? Another way to kind of use and break through these myths is really just digging at the core issue, which is, I ain't getting paid for that. I don't get reimbursed for doing an extensive med review. Why should I bother wasting my time? If you are showing that you are reducing harm by stopping harmful meds, and maybe showing you're reducing falls risk, or reducing readmissions, or reducing pill burden, or hitting on stopping constipation, or improving customer satisfaction, right? All of these metrics I've listed are literally HEDIS measures, if not HCPCS measures. And this is what facilities get reimbursed on. So if we're reducing those numbers, guess what? You're reducing costs. If you're reducing costs, you can leverage and sell that to small insurers and qualified improvement networks and quality improvement organizations and other population health models that look at reducing cost. So cost reduction is the name of the game, people. And that, my friends, is sellable. That is what you can leverage with this type of service. And another way that we can kind of achieve this myth of just handling this thought process is make those pharmacists your BFFs. I mean, we don't bite. We don't bite. We know the meds. We know how to deprescribe. We know how to get you off of them safely. So consider having a program where you roll out a pharmacist who works for your facility and does the deprescribing for you. And guess what? You can still make that a sustainable, monetizable revenue stream for your business. So we touched on a couple of myths today. So let's dig into why the Deprescribing Accelerator is different. Why do we make this process easy for you once you use our program and roll out and implement into your business? We help you with developing, number one, an easy to follow deprescribing toolkit. So basically, you're going to have step-by-step what types of questions you should ask and when in clinic, so you can have your ammo lined up for your patient and your provider, and the buck doesn't just fall on you. Now we have a team-based approach on addressing some of those opportunities for deprescribing, okay? So number one, have the deprescribing toolkit that you will get and use after our program. Then, of course, number two, team-based care, interdisciplinary approaches. We all need each other as clinicians in this game to really unify and move those metrics of reducing harm. So when you have a team that is enlightened, is educated with a mission and goal to reduce opioid use in a nursing home or stop NSAID use in my community pharmacy for all my heart failure patients. These are concrete, tangible examples that are being done today by pharmacists, by pharmacy technicians, by nurses, by social workers. It doesn't take just a doctor to deprescribe. We all have a role to do this, and that's why I'm so passionate about talking about this. And then lastly, another thing you could use is leveraging someone who has an expert in genetic testing, someone who could use genetic testing as not only a revenue stream, but another avenue for deprescribing. How many seniors are on psych meds, are on have cardiovascular issues, have cancer, have all types of chronic morbidities, and yet and still, genetic testing is still very much new to the medical community. Like, what is going on? Where's everybody been at? It's been around for 25 years, but it's taking pharmacists like myself and others to break through from this mold and change our system and integrate this into care models that exist now. That exist now, okay? So there are so many myths out there. I hope you all took away some amazing points. The truth is, you got to start leveraging your pharmacists. You got to start contracting with them. You got to start using deprescribing advocates and use what you will take away from our Deprescribing Accelerator to, again, grow your practice, grow your clients, get those referrals, and get some added revenue during a very tough time. So again, I'm Dr. DeLon Canterbury. Hope today was helpful for you. What resonated with you the most? Leave your comments below. I would love to hear and see them. But what were some other myths that come up to you about deprescribing? Hopefully today resonated with you. I would love to know your thoughts. Comment below. We do have room. We have 4 more people left to join our Deprescribing Accelerator. We start in June, so apply at geriatrx.as.me, which we have in the description above. So you guys take care. I'll see you next time for our next movement. Choose the red pill. Do not choose the status quo, and better advocate for those patients. Take care, guys.